Hey everyone, welcome back to another video. My name is Dr. Sahan Hushman and I'm a lecturer at Sydney Uni and a radiographer at Loomis Imaging. And one of the most critical skills you need to know how to do as a radiographer, and really as a health professional, is to be able to know whether an X-ray is good or not. How and whether or not it needs to be improved, aka if it's diagnostic, and also if you need to repeat the X-ray. So how exactly do you do all of that? Well, in this series, of which this is the first video, I'm going to be taking you through how to critique radiographs so you'll know exactly what you're meant to be looking for, of course starting off with the chest X-ray. So in this video, I'll take you through how to critique a chest X-ray using the PACEMAN image evaluation technique, which by the way doesn't just apply to chest X-rays, but really any region of interest. I'll take you through 4 different examples, starting off with what a normal chest X-ray should look like, and then looking at some that could have been improved. And in future videos, I'll go through certain pathologies and what you could expect to see and what they look like, so comment down below what you want covered. Now, the image evaluation technique that we usually employ to critique chest X-rays is called PACEMAN, which stands for positioning, area, collimation, exposure, marker, aesthetics, and name. So let me explain what each of those are and what exactly we're evaluating. By the way, if you already know this part, then you can skip to the first example at this timestamp. Positioning really refers to whether the patient is in the correct position. Are they rotated? Are they tilting left or right? Are they leaning back and forth too much? Does the image correctly show the needed joint spaces? That kind of thing. Area refers to whether there's enough of the anatomical region of interest that's been covered. Has there been anything cut off? Or has there been any area exposed that didn't really need to be? Really addressing whether or not the relevant bones and organs of interest are being obscured in any way. Collimation is similar to area, but is mainly referring to how well the beam has been collimated side to side and top to bottom. As it hasn't been collimated too tightly, potentially cutting something off, or is it too wide, exposing an area and also degrading the image quality through the increased scatter. Exposure is really referring to the KVP and the MAS that was set. Like, was it appropriate for that region of interest, size and density? How does the image look in general? Like, does it have enough contrast? Is it good enough contrast density? Is there too much noise, aka the quantum mottle, which is that graininess that you see when you have low MAS? And if you have an exposure that's too high or too low, how would we need to change it in order to produce a better image? Markers is an easy one. It's obviously referring to whether you have your left or right markers included, and if there was, is it on the correct side, and if it's facing the correct way, and if it's back to front or not, that kind of thing. But it's not just the left or right markers, it could also be the markers that were post-processed on. For example, was it taken supine or erect or weight bearing, etc. Aesthetics is an interesting one. It's basically asking whether an image looks nice to look at. I like to think of it as a combination of all the previous ones above. As in, is it centered properly? Is the 4-way collimation good? Does the exposure make it look okay? And you know, some people also use the letter A in this case to look for artifacts, because depending on whether it's a physical artifact or post-processing, it can cause an effect on the image's aesthetics. And lastly, name, which really just refers to whether the image correctly identifies the patient. Does it have the proper name, date of birth, examination details shown, etc.? Does it have any other relevant identification details present? That kind of thing. And for university and exam purposes, for the most part, this one's always a freebie because any image you get given or seen is always going to be anonymized. So you can say something like no name or patient details are seen, as they have been anonymized. All right, so now that you have an idea of what PACEMAN is and what each letter stands for, let's go through some chest X-rays to put it all together, shall we? Okay, so when we look at a chest X-ray, what are the anatomy that we're meant to see on there? Obviously, the first thing is the lungs. That's the star of the show, making sure that we have from the top of the lungs all the way to the costophrenic angles at the bottom on both sides, and making sure that you have the sides as well. We also have the heart. Okay, so when we're looking at the heart, we want to make sure that it's the correct size, given if it's taken in the PA orientation. So what we usually do is look at the cardiothoracic ratio, which is the distance between the heart and the edges of the lungs, and making sure that's less than 0.5. We also look at the shape and position of the ribs on each side. Okay, how many ribs you're meant to have is an important indicator of how well the patient has breathed in or not breathed in. The actual shape of the ribs itself, whether it's too flat, whether it's too rainbow-like looking, all of those things. We then have the clavicles on the top over here on both sides. Whether it's angled in a particular manner or if it's too high or too low, that can indicate certain positionings. We then have in the middle the thoracic spine and the sort of the mediastinum, which puts all those structures together. the scapula, which in this case it's a little bit sort of in the way, and also any potential soft tissues such as the chin if it's really low, or if it's patient's a female, breast tissue towards the bottom over here. So those are the types of organs in anatomy that we're expected to see. Again, the heart, lungs, ribs, spine in the middle, clavicle, and the scapula. Just so the things to be aware of when looking at a chest x-ray. Now let's go through PACEMAN and see how we can evaluate the image in terms of its quality. So the P in PACEMAN stands for position. Okay, so evaluating the position of this particular x-ray, we have to ask ourselves, is the patient rotated? Is there any tilt? Are they leaning back and forward? And so the question is, how do you do that? Well, are they rotated? Are they not? There's a few ways we can tell this. One of the main ways is to look at the medial borders of the clavicles. If I sort of zoom it in over here, the medial borders of the right and left clavicle are here, and they ideally should be equidistant to the spinous processes on the back. So if that distance is equidistant, meaning it's the same, then it's a good indication that there was no rotation. If one side was smaller than the other, then it would indicate that there is some rotation. Okay, so for example, if there was more distance on the right side than on the left side, then you can assume that the patient was rotated on their left, aka their left shoulder was more closer to the board for whatever reason. But that of course assumes that the patient's spine is straight and there is no scoliosis to affect this positioning. If there is scoliosis, then this metric doesn't really apply. And another factor that you can look at is just the symmetry of the ribs. Okay, so is there roughly the same amount of bowing on each side, or is one side really different to the other, aka asymmetric? That's usually another good way if the medial borders of the clavicle don't work. However, it is worth noting that if there is a severe scoliosis in the spine, particularly the mid to upper back, mid to upper thoracic area, then that would also distort the ribs in this case. So looking at this particular x-ray, it doesn't look like the patient was rotated in any significant manner. The next question is the patient tilted left or right? And for that, the best way I've found is to look at the x-ray sort of almost with squinted eyes, looking at the lungs to see if it is sort of rotated in any one direction. And in this case, it doesn't really look like it is. The patient's apices of the lungs are pointing straight up in both areas, and there's not much of a tilt in each area. So all good in those regards. Now, what about if the patient is leaning forward or back, right? So if the patient is leaning forward, whether that's intentional or whether their spine is sort of in that position, that's called kyphosis. And if they're leaning backwards, then that's called lordosis. And the way we tell that is in two ways. So I'm just going to rub this out. The first way to tell if a patient is kyphotic or lordotic is to look at the position of the clavicles. Now, generally in a well-positioned x-ray, you should see about 2 to 3 posterior ribs above the clavicle. So in this case, for example, this is rib number 1, that's rib number 2, and that's rib number 3. And so roughly this amount of space, you should be able to see a little bit of the lung apices, which indicates a normal positioning of the patient. If, however, the clavicle is really high and it's almost covering the top of the apices, or even worse, it's sort of up here, it's completely above the lungs itself, that is indicating that the patient is being lordotic, aka leaning backwards. And also what happens with that is that your ribs tend to look a lot more flat as well when that happens, okay? So when that happens, we say lordosis or lordotic, okay? That's when the patient is sort of leaning back, the clavicles are elevated, and the ribs are a little bit more flat. The alternative to that is if the patient is sort of kyphotic, sort of leaning forward a little bit. What happens then is that instead of the clavicles being in this position, they might be a little bit lower, something like that. And the ribs themselves have a lot more of a rainbow-like appearance. They're a lot more sort of tilted in that regard. And this is suggesting kyphosis, okay? So the patient is basically leaning forward, either because that's the position of the spine, or maybe they weren't positioned correctly. Now, another thing that we look at in terms of positioning is the actual position of the scapula. Okay, so I'm just going to rub these out. Is the scapula rolled out of the way? So ideally, when we position for chest x-rays, we get the patient to roll their shoulders forward. So ideally, the medial borders of the clavicle of the scapula are not in the way. Now, in this case, you can see that the edge of the scapula is right here. Okay, so they haven't really rolled it forward. That's the patient's right scapula, and the left scapula is over here. So the medial borders of the scapula are within the lung field, It's not the end of the world, but ideally they should be rolled forward so it's not within the lung field. So that's the scapula. Now I also mentioned the clavicle in terms of whether the patient is leaning forward or leaning backward, aka kyphosis or lordosis. So that will indicate whether it's quite high or it's quite low. But the clavicle can also be angled as well. So it can be angled very steeply like that, or it can be really, really flat, okay? And generally, if the sort of the medial end isn't really too high or low, and it's just the whole clavicle itself is angled quite a bit, that generally is indicating that the patient's shoulder was just really high when they were positioned, okay? So if the patient's shoulder is really high and they roll their shoulders forward, or just high in general, that makes the clavicles angled a lot more than they otherwise would be. Okay, so that was the position. Now the next letter in the PACEMAN is A, area. Okay, so area is really referring to, is the region of interest covered adequately? AKA, has the lung been cut off in any particular manner? Well, in this case, we can see the top of the lung really well. We can see the side, we can see the costophrenic angles on both the left and the right side. So no lung has been cut off in that regard. So that's pretty good. Then we ask ourselves, okay, well, what is the heart size? Okay, so if we get the measurements from here to here, whatever that measurement is, and the measurements from the edges to the edges of the lung, that value, so the heart to the lung ratio, so the H divided by L, should be less than 0.5. Okay, if it's less than 0.5, then they have a adequate or ideal cardiothoracic ratio. And this is assuming, by the way, you do the X-ray in the PA position, not the AP position, as that causes magnification. Okay, so for example, if I take the measurement here, so that is 6.7 centimeters, let's say, and the other one is, let me draw another one here. The edges are around, let's say, 14.8. So this one was 6.7. So if I bring up my calculator over here, we had 6.7 divided by 14.8. Okay, so that is 0.45. So that is under the 0.5 cardiothoracic ratio, so it's an adequate heart size. Now the other factor is how well has the patient breathed in. Now after a while of looking at chest x-rays, you can kind of tell if it was a good inspiratory effort, but a good way is to count the ribs. And ideally we want to be able to see at least 10 to 11 or 10 to 12 posterior ribs, okay? So if I just basically zoom in and let's count how many that we see, okay? So this is rib number 1. Okay, you might actually just rub out this top one so we see exactly what's going on. So this C-looking shape here, that's rib number 1. Okay, then this one right below it there, that's rib number 2. This is rib number 3, 4, 5, 6, 7, 8. I'll scroll down, 9, 10, and a tiny bit of 11. Okay, so that's pretty good. It's above 10. Now, if I see anything less than 8, then that usually means they didn't really try enough, or maybe that's all they could do. But if they could do a better one, it's worth repeating. But this one is definitely in the green, so over 10 ribs or over 10 posterior ribs visible, which makes it a good inspiratory effort. Okay, so that's pretty good. And that was area. Now the next letter is C for collimation. So we're going to write that in. And collimation is essentially talking about the four-way collimation on each side. Is it too little? Is it too much? So collimation. Okay. In this case, because there's nothing cut off on each side, then we can say that it's not really too narrow in terms of its collimation. So the next question is too much being exposed? So on the side, there's only a very little amount on each side that's been exposed, and similar to the top and the bottom. Okay, so there's not much that's been exposed that's too much. So in this case, the four-way collimation is really good because of that reason. It's not really exposing anything that it's not meant to. It's only mainly exposing the region of interest, which is the lungs in this case. The next one, E, is talking about exposure. Okay, so is the KVP and the MAS adequate? How do we know? Well, we usually look at the level of contrast and the level of noise or the quantum mottle in the image. Now in this case, looking at the contrast itself, it looks quite adequate. Okay, I wouldn't say there's anything, too contrasty or not enough contrast about this. So, KVP seems to be pretty good. And in terms of the quantum mottle, if you zoom in, there's always going to be obviously some level of quantum mottle or sort of that graininess or the noise in the image. but in this case it seems quite adequate. So maybe there's some in the denser areas in the shoulder or maybe the lower abdomen area, but that's not really the region of interest, right? So we're interested in the lungs. So I would say in this case even the MAS is quite good. Exposure is quite nice overall because it's showing us the region of interest nicely. And for chest x-rays in particular, a good way of knowing if it's been penetrated adequately is to look at sort of the mid-thoracic area and see if you can look through those joint spaces. And in this case we can, so there's a relatively adequate amount of penetration and contrast and low noise levels throughout, so good exposure. Okay, so next is marker. Okay, so this one's pretty easy. It's really asking us if the right and left markers are on the image, whether it's done through post-processing or if it's done we're using the actual physical marker. It doesn't just have to be the right marker or left marker. It could be if it's done erect or weight bearing or supine, whatever the reason may be. Now, in this case, they have the letters DX and SIN, S-I-N. Now, I do believe these do actually mean right and left. So in that regard, their markers are in the correct place. Remember that our left is the patient's right and our right is the patient's left, okay? Because you have to look at it as though the patient is looking at you and standing in front of you when looking at these x-rays. The other thing is that the marker is not really in the region of interest. It's not covering the lungs. It's not covering the clavicles or the shoulder or the humeral head. So in that regard, it's good. The main thing is that if it was covering the lungs, then that would need to be repeated. If it was slightly covering the clavicle, then not too big of a deal, but generally it's not ideal to have that because it might be masking some underlying pathology. After marker, then we have aesthetics. So aesthetics, okay, this is really just referring to how the x-ray looks like overall. Okay, so it's like almost like a combination of everything we talked about. Is there a lot of rotation or tilt? Is the exposure really bad? Is the collimation out of whack, etc.? In this case, all of the above seem to be quite good. So in terms of aesthetics, it's a really nice looking image to view. And oftentimes in this A category, we also talk about artifacts, okay? Artifacts, okay? Whether the patient has some kind of necklace, whether they have sort of bra clips or bra wirings, or nipple piercings, whatever the reason, whatever the artifact may be, that's also something to talk about. But in this case, there doesn't seem to be any artifacts on this image. And lastly, we have name. And for name, and this is basically referring to, is there any patient information or demographics on the x-ray? And again, if you're a university student or getting this in an exam, it's always going to be a freebie because they're not going to give you the patient name. So you can always just say something like no patient name or details identified because the image is anonymized. So that one is always easy. Okay, so that's basically our first example, case one. Overall, we said that it's a pretty good x-ray. We went through the PACEMAN criteria and we're happy with this. So would you repeat it? Definitely not. Okay, there's no reason to repeat this one. Is there any pathology? Not really, no pathology of interest. So this gas bubble down here, by the way, is just the gas within the stomach. So that's quite normal. Within the lungs itself, obviously you can see the lung architecture throughout. Sometimes these areas are a little bit more whiter than the outer areas. That's just because that's where the primary or secondary bronchi are. It looks like it's within normal limits. If it was a little bit more radio dense, then you would potentially conclude that there's some kind of bronchitis or some level of infection, but in this case it's all within normal limits. So the things again you would improve about this one is not really anything substantial. I would probably next time, if I had to do this, get the patient to roll their shoulders forward so the medial borders of the clavicle are out of the way. Otherwise everything else is pretty good. All right, so now let's move on to the next one. Okay, so here's our case number 2. Again, a little bit different of an x-ray. Again, going through our PACEMAN criteria. So the first one is position, okay? Positioning, again, we're referring to, is the patient rotated, tilted, kyphotic, lordotic, etc. Now, is the patient rotated? Well, again, if you look at the medial borders of the clavicle, let's zoom this in a bit. So that's the medial border of the right one. That seems to be the medial border of the left one, and that's the spinous processes. Okay, if you look at the overall position of the thoracic spine, there doesn't seem to be much scoliosis. It's relatively straight, so we can kind of conclude. See how this distance is quite small compared to this one. Okay, we can probably say that the patient's left shoulder was a little bit closer to the board compared to the other side. So a slight rotation because of the medial ends of the clavicles are not equidistant from the spinous process. If you look at it overall, there is a slight asymmetry in terms of the positioning of the ribs as well. This one seems a little bit more sort of elongated compared to that side. That's another way that you can tell. Now, that's rotation. Is the patient tilted? So again, kind of zooming out, squinting your eyes a little bit, asking yourself, is the lungs tilted left or right? Probably not much significant, if anything, very slightly towards the patient's right, but it's very minor, so I wouldn't really worry about that one. The other question is if the patient is really kyphotic or lordotic. Again, I can see 1, 2, and roughly 3 ribs above the clavicle, so the clavicle positioning seems to be in an okay position. The angle of the clavicle itself is within normal limits, so I wouldn't say the shoulders are necessarily raised or lowered in any significant manner, and there doesn't seem to be much kyphosis or lordosis in that manner. The position of the scapula, again, so the medial borders are sort of within the lung field, which is not ideal. They should be rolled forward so they're out of the way. So that's something that's sort of covering the lung field in a minor manner. And I think that's pretty much it for position. Okay. So the next thing was area. Okay. Is the area or the region of interest sufficiently covered? So I'm just going to rub these out. Area, we're talking about the lungs, we're talking about essentially the heart, and potentially and how many ribs we can see. So if we look at the lungs, we can see the top of the lungs very well. We can see the costophrenic angles on the bottom. Nothing's been cut off from the side, so that's quite nice. All of the lung is essentially visible. Now the question is, how much have they breathed in? So how much of the lung can you actually see? Well, for that we need to kind of count the ribs. So if I just zoom in a little bit here, okay, again, that first rib is always that sort of C-looking shape. So that's rib 1. This is rib number 2. Okay, this is rib 3, 4, 5, 6, 7, 8, and a little bit of 9. Okay, so we see about 9 ribs. 9 ribs and basically not really 10. So I would just count that as 9 ribs. Again, is that ideal? Not really. Just looking at the chest x-ray itself, you can tell that they could have done a little bit more of a better effort in their breathing in. So in this particular case, I wouldn't necessarily just repeat it. I would ask the patient, hey, is that the best effort that you could do? If we were to repeat this, do you think you could do a better inspiration? And if they can, might be worth repeating, although it's borderline. And then we have the cardiothoracic ratio. So again, if we get my trusty line over here, so the edge of this is about 7.6. Okay, 7.6 centimeters. Let me write that down before I forget it. 7.6 centimeters. Okay. Oops. Centimeters. And the edges of the lungs are how much? Okay, so edges of the lungs are roughly 16.25. Okay, so 16.25. Let's write that down. 16.25. So we basically want 7.6 divided by 16.25 to be less than 0.5. Okay, so if we bring up our calculator, okay, clear that. We want 7.6 divided by 16.25. Okay, so that's about 0.46 under the 0.5, so quite good in terms of the cardiothoracic ratio being less than 0.5. Okay, so that's area done. The next thing is collimation. Okay, so again, looking at the 4-way collimation, is it good, is it bad, could it be improved, etc. Now the top is pretty good. Okay, you have the top of the lungs, and this is essentially, you know, C7 right at the top. So top is okay. Side to side could be improved. Okay, side to side could be improved. Particularly, they could just collimate it in a lot more. Particularly the patient's left side as well. So if one side is usually more than the other, it just means that they weren't centered correctly. So if you center the patient a little bit more, aka moving them towards their left side and then coning in side to side, that would help quite a bit. Okay, and also top to bottom, again, the top was okay. The bottom, it seems to be like a lot of abdomen in here. We mentioned earlier that they maybe could have done a bigger breath in. So if this is 9 ribs and they potentially breathed in up until here, that would have made it a lot more adequate. So you can position, all you want, but if the patient doesn't breathe in as much as you want them to, then it's not really ideal. And remember, if you recall from your chest x-ray tutorials and lectures, the centering point for a chest, assuming they breathe in adequately, is roughly T7, thoracic vertebra 7, which roughly aligns with the base of the scapula. Okay, so the base of the scapula, if it is here, that's roughly the center of the image. Okay, again, assuming that they do a really good breath in, which in this case, it doesn't really look like they have. Now, in terms of collimation, I'm not really sure what's going on here in terms of that sort of difference in brightness contrast. But one thing you can tell if the image was post-processed in terms of its collimation, or if it was actually using the physical collimation that happened in the X-ray room, is what's called that sort of silver lining effect. So see how here, there's like this white halo effect, and on the top, you don't have that effect, okay? Even on the bottom, you don't seem to have that effect. So when you have that sort of white glowing effect, that means that was the actual edge of the collimation. But if you don't have it, that usually suggests that there is a post-processing collimation that was done. Okay, so that's collimation. The next one, PACEMAN, is exposure. Okay, so exposure again is looking at the KVP and the MAS. In terms of the contrast, it seems to be quite good. I wouldn't really say that the lungs are overly contrasty or not contrasty enough. So KVP seems to be quite good. The quantum mottle, again, I wouldn't say that there's any excessive quantum mottle anywhere. If I even zoom in, the lung itself seems okay. Now, it's a different story if you see a lot of graininess in the abdomen area, or maybe in the sort of the shoulder area over here. So that's not too big of an issue. So exposure seems to be adequate for this patient. Now, usually what you might see is densities towards the lower area of the lungs, and that's usually because of the breast tissue. So in this case, the lung hasn't been affected, but if you just follow this sort of line around, that is basically the patient's breast tissue, and which in some cases, if they do breathe in quite a bit, can affect the exposure that you see in the lower parts of the lung, and it sometimes seems to mimic like it's a lower lobe pneumonia, but it's really not. Again, another thing we can look at is sort of the mediastinum in the middle. We can kind of see through the thoracic vertebra, so there's adequate amount of penetration. So exposure, I'm pretty happy with it in this case. Next one is M marker. Okay, so in this case, marker, the left marker has been placed in the correct orientation. So this is the patient's left side. Again, that is our right, but it's the patient's left. So the marker has been put on digitally. Now it is covering sort of the humeral head in this case, which may not be ideal. They could have maybe put it up over here or somewhere over here, given that it was digital, so it's not really gonna, you do it after the fact, but it doesn't seem to be too bad of a position either. Okay, so that's marker done. The next one is aesthetics. Aesthetics. I can't spell aesthetics, can I? Aesthetics. Now, in terms of aesthetics, again, there's a lot of lines on the display right now, but the main thing for me is that there's just too much, the collimation is too wide. They should ideally bring the collimation down to make it look like more of an aesthetic image. What was the other thing in terms of aesthetics? It was artifacts, right? Artifacts. Doesn't seem to be any artifacts in this particular image, so I'm pretty happy with that. That's fine. And the last one, N, which was name. Again, obviously no name in this image, so no name presented because of anonymous reasons. That one's always a freebie for you. All right, so that was case number 2. Hopefully it made sense. Now let's move on to the next one. All right, what do we have here? So just by looking at this x-ray, you can kind of tell it's not the best, right? Whether it's due to patient positioning or some kind of pathology or poor technique, etc. Anyway, let's go through our criteria. The first one was position, okay? So position. Is the patient rotated? Are they tilted? Are they kyphotic, lordotic, etc.? Okay, so looking at the medial borders of the clavicle, it's hard to tell, but that's the right border there. This is the left border, and this is the spinous process. Okay, so obviously there's a bit of a equidistant relationship between that. So usually you might say that the patient is rotated quite a bit. However, the spine is not heavily, or sort of mild to moderate scoliosis. So in that case, we can't really rely on this metric. And you can tell that because of that rotation of the spine, you can actually see the ribs being asymmetric as well. Okay, so look at those ribs compared to these ones. They just look very asymmetric. So in this case, it's very hard to tell if the patient is rotated, just given the scoliosis that's present. The other question is there any tilt in the patient? Again, if you just squint your eyes, it kind of looks like there's a little bit of tilt towards the patient's left, but I think that's just the illusion that you get looking at the scoliosis of that patient. Are they really hunched down or leaning back? How many ribs can we see? Again, this one's a bit difficult. So that's rib number 1. That's rib number 2, 3, and 4. Okay. If you missed that, let me do that again. Okay. So rib number 1 is always that sort of C-looking shape. Okay. Rib number 2, again, is sort of mostly overlapping. It's right there. Okay. Rib number 3 is right below that, and then this is rib number 4. So about 3 to 4 ribs. You can say maybe it's slightly kyphotic, and you can compare these ribs and how sort of rainbow looking they are in terms of how bowed they are compared to the previous 2 x-rays, so you see what I mean. But I wouldn't say the kyphosis is there to any significant degree. Looking at the position of the scapula, again, this one, the scapula is inside the lung field, so not ideal. Okay, they should have had the patient sort of roll their shoulders forward. However, we can kind of see that this x-ray was taken in the AP orientation, and it says semi-erect, meaning they were not standing up in the PA position that you would normally have them. They were sort of sitting up halfway, and they're in the AP position, so they're facing the x-ray tube. And this usually just tells you about the situation of the patient. Maybe they were in ICU, maybe they're not well enough to come down to the x-ray room, whatever it is. So usually we can excuse the shoulders not being, the scapula not being rolled forward if we see that they've done it in the semi-erect position, or rather AP and semi-erect position. So that's the positioning done. Okay, not ideal, but it is what it is. The next is the area. So is the area covered? Again, looking at the lung field itself, we have the top that's covered, we have the cosophrenic angles that are covered, so nothing's been cut off, so that's quite nice. Again, looking at the amount of lung that we see, which we determined by the amount of ribs that we can count. So I'm just going to rub these out so we can properly count the ribs. Okay. So zooming in, let's get really detailed with this, even though it's not really a detailed image. So that's rib number 1. Okay. Right below it is rib number 2. That's rib number 3. That's 4, 5, 6, 7, 8, I think that's 9, and a tiny bit of 10. Okay, so pretty good, all things considered. If it's an AP semi-erect position, you just see about 10 ribs, so I wouldn't necessarily repeat this, but you can kind of tell that it would have looked like more of a nice chest x-ray if there was more of the lung present, but definitely within the normal limits. Again, looking at the cardiothoracic ratio to see how big the heart is or is not. Okay, so that's roughly that, 7.66. okay, and if we do the edges of the lung, that's about 415, let's say. Okay, so 7.66 divided by 15, 7.66 divided by 15, and that is 0.51. Okay, so borderline just above the 0.5 recommendation for the cardiothoracic ratio. So in this case, it seems to be over that 0.5 cardiothoracic ratio. But again, remember that this image was taken in the AP orientation, which means that there is going to be some magnification of the heart just because it's done in the AP. The heart is a little bit more anterior in the thoracic cavity, and so when you do the x-ray in the AP position, there's a bit of a gap and therefore results in a magnification. So again, what I'm trying to say is that if you have an AP orientation and you see a cardiothoracic ratio of slightly over 0.5, that's actually okay, because that metric doesn't apply for non-PA images. Okay, so that's the area. Then we had collimation. Okay, so again, we're getting pretty good at this now. Collimation, top seems to be okay, right? The bottom, again, seems to be okay. Maybe they could have brought it in a little bit, but side to side, it could have been improved, right? So side to side collimation could have been improved. In fact, you can see half of the humerus in here. So ideally, we don't want that in there. We ideally get the patient's arms like this, so the shoulders are out of the way and the arms are out of the way. But again, this is done in the semi-erect AP position, so not faulting them too much in that regard. So collimation could have been improved side to side and slightly top to bottom. The next one is exposure, okay? So just looking at this image, to me it looks very contrasty, right? You see a lot of darkness in here, and then all of a sudden too much whiteness. So this potentially suggests that it's a relatively low KVP. KVP could have been increased. And I can tell it's a low KVP because one of the other metrics that we looked at was the penetration of the mediastinum. So in this area, it's very hard to actually see the joint spaces of the thoracic vertebra, which means it's not penetrated enough, so not enough KVP. MAS as well, I would say it's slightly low. Now this may be just a poor quality image from the internet, but just looking at, if I zoom into the lungs itself, okay, it seems a bit grainy. Okay, so I would say probably low MAS on this one. Both of them would need to be slightly increased for this to look quite nice. And definitely there's a lot of quantum mottles sort of down in this abdomen area, which is expected, but you know, that's what you see there. Okay, so that's exposure. The next one is marker. Is the marker in the correct position? So there's a right digital marker on the patient's right side, so that's correct. It's telling us that it was taken in the AP orientation and semi-erect. So that's all well and good. Not too bad of an issue. Markers are all there. That's done. Aesthetics is the next one. Okay. How does the image look overall? Not the best, right? So the exposure is kind of off. There's it looks very contrasty. The noise levels could improve. The patient's arm is in the way. The scapula is sort of not removed from the image, and overall not the best aesthetic. Now in terms of the artifact, there doesn't seem to be any artifacts in this case. Okay, by the way, so this is the aortic knuckle, so that's just the aorta coming down, and we have the hilar region in these areas, and then the ribs and the lung architecture itself. So that's aesthetics done, and the last one was name. Okay, so obviously no name in this one present because of anonymous reasons, and so that's taken out of the picture. Okay, now would you repeat this X-ray? I would probably not repeat it because you have relatively adequate inspiration. The lung areas are not really cut off. You see the cosophrenic angles, you see the top, you see the sides. Exposure could be slightly improved, but it's nothing that's making it undiagnostic. So that's in regards to that. In terms of pathology, the lung seems to be okay itself. I'm not convinced there's any sort of major infection, but if you did recall over here, there's actually a fracture in the patient's clavicle. So you may or may not have noticed that one, but that is the case in this case. I'm not sure if it's a recent fracture, but that is something that's visible on this X-ray in terms of pathology. Okay, so that was case number 3. Now, again, hopefully you're getting the hang of this now, and we have one more to go, so let's talk about the 4th case. Okay, so the last case, a lot going on here. Now, hopefully just by looking at this, you can tell that it's not the best X-ray, but if we were to evaluate it with PACEMAN, let's see sort of where it takes us. Okay, so again, positioning was our first metric. Position, is the patient rotated, is the patient tilted, is the patient kyphotic, lordotic, etc. Okay, so bit of a blurry image, but see that's roughly where the medial border of the right clavicle is. That's roughly where the other one is. Spinous process in the middle, roughly equidistant. I wouldn't say there's too much, maybe very slight rotation. In terms of tilt, if you just squint your eyes, it seems like it's very slightly tilted to the patient's left. Very minor, not too big of an issue. The main issue here for me is that the clavicle itself is quite high, okay? In the sense that this is rib number 1, rib number 2. So you only see about rib number 1 above the clavicle, or essentially it's overlapping rib number 1. And so what you see, if the patient's clavicle is kind of raised up quite a bit, it means that they're lordotic, so they're leaning back for this X-ray. Okay. Now, what you can also see is how the ribs are quite flat, right? They don't have that rainbow or bowed appearance. They're quite flat, which is in keeping with lordosis, or the patient being lordotic, etc. Okay, so that's positioning done. Also, the position of the clavicles, it's very hard to tell, just given how blurry the image is. That's the edge of the clavicle there. It's almost very hard to tell. I might say that's the edge of the scapula, and it's very difficult to see the one on the right hand side, but that's position. The next one is area. Is the relevant area covered? So we've got the top, nothing's been covered in terms of the cosophrenic angles and the diaphragms on the side. How well are they doing a breathe in? Okay, so if I take a different colored marker, so that was, rib number 1. Okay, let me just actually wipe all of these just to make sure I'm counting this correctly. Okay, so we have rib number 1, that's 2, 3, 4, 5, 6, 7, and a bit of 8. Okay, so not a good inspiration. They probably could repeat this one, not just for the breathing in, for many other reasons, but not the best inspiration in that regard. And again, yeah, scapulas are very hard to tell. Anyway, so that was area. Then we had collimation. Okay, sideways collimation seems to be quite good. There doesn't seem to be excess on each side. Okay, top to bottom is also quite good. However, we don't really see that silver lining effect, so it may have just been post-processed in terms of its collimation. Okay. Exposure. Not the best exposure. Okay. Oh, by the way, something I forgot before moving on to exposure was the cardiothoracic ratio, so let's quickly do that one again. Okay. So just by looking at it, it seems like it's borderline, but let's do the calculation. So the edges of the lungs, 9.46. Okay. Let's bring that up. So 9.46. And let's see what the other one is. 19.04. Let's call it 19. So 0.49. Okay, so borderline, it's under the 0.5 cardiothoracic ratio, so we're going to call that to be okay. Anyways, go back to exposure. We say that the exposure doesn't really look good. Okay, it seems to be quite contrasty, very noisy in its quantum motile. So I would say, low KVP and also very low MAS. Okay. It's not necessarily blurry, although it kind of looks like it is in some areas. If you couldn't see the diaphragm very clearly and it was kind of blurred, you can see a double line. Maybe you could make the argument that the seconds in the MAS was quite high, or the patient didn't stop breathing in time. So the MAS, you could adjust the MA and the seconds portion separately and to bring the seconds down but increase the MA. But either way, the MAS is quite low on this one. And so exposure could definitely be improved. The next is marker. Okay, so I don't really see any markers on this, so not ideal. If it was to be put digitally, I would put like a left marker in this case in there, or a right marker above the region of interest to make sure it's indicating the right area. Marker, next one is aesthetics. Okay, terrible aesthetics, right? Doesn't really look good, both in terms of the lordotic nature of the patient, the poor exposure, and just the fuzzy blurriness lookingness of the image. So not the best aesthetics. Doesn't seem to be any artifacts either, right? So no artifacts seen in this case. So that's done. And the last one was name, right? So no name on this patient's X-ray or this file for anonymous reasons. So again, that one is the freebie. So again, I hope this is all making sense. I showed you 4 different cases. This one I would definitely repeat just because of how poor the exposure is and how little you can see of the lung architecture itself. So I think this would definitely benefit from a repeat. But I hope you're getting the hang of what different chest x-rays look like, what to look for, going through that PACEMAN criteria, which is, I think, something useful that you will hopefully use in the future and with other areas of interest that we'll go through later. All right, that's it for this one. I hope you got some value out of it, and I hope you now see what different chest x-rays look like, what normal looks like, and how if something is abnormal or it has pathology or it's just a poor result of positioning and technique, how it can be improved. Now in future videos, I'll be taking you through other regions of interest, so be on the lookout for those when they're ready. But for now, click here to watch my playlist on the different x-ray pathologies, which I think you'll find quite useful. All right, see you in the next one. Stay curious.